Cast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. This is Mark Lynn, and you are tuned in to the Major Changes in Cost Reporting for Rural Health Clinics session. This is going to be directed specifically to independent RHCs, but if you are provider-based, some of the information will help you as you prepare your cost reports as well, or gather your information for that. Please stay with us, because I know I saw some provider-based RHCs on the name list over there. My name is Mark Lynn. I'm a CPA from Chattanooga, Tennessee, and there is my contact information. You can get a hold of me. That phone number is my cell phone number, so if you want to call, text, feel free to at any time, and my email is there if you want to email any questions that you have. Danny Gilbert, CPA, is online with us. She'll be helping me out with some of the details on this cost report information as well. Between Danny and myself, we do about 150 of these things every year. So it's that time of year when we're going to be super, super busy. I sort of dread it, especially this year with all the changes. It's going to take us longer to do these cost reports, so we're going to want you to get your information in earlier. But there's Danny's contact information as well. If you've not already joined the Facebook group called Rural Health Clinics Information Exchange, I'm going to take you there right now, and you can just take a look at it, and you can see we tend to put a lot of information on there. There's about 577 members, and like I said, we post information there all the time. People ask questions on there all the time, and it's not just me, it's other consultants who are really, really good are on there, and they will answer your questions as well. So do join that if you haven't already. That will be very helpful in getting information to you quickly, and you can find out about webinars and free information that we send out to you guys very quickly. There's somebody already joining. Well, thank you. So there's several people. Very good. You guys are listening to me. This is a miracle. But what we do 150 cost reports every year, which is, like I said, it's going to be hard this year. We do a ton of annual valuations, a ton of RHC startups, and we do, and there's a brochure here that says all the different things as far as cost reports, what our process is here. So if you want to look at that, we also have 5 files that are over on the side on your handouts which will have this presentation in there. The links will be active, so you guys can just click in there and click on anything that we have on this presentation today. You'll be able to take that and use that. Disclaimer, information is up to date as of today. So as of 2/7/2019, everything is up to date. This session is being recorded, so you guys can listen to it later. Or I've had several people say they couldn't be here. Will you record it? We will do that, and we will post it. We have a YouTube channel that we will post that to, and you will be able to link to it. We'll also post it in the Rural Health Clinic information exchange group, so you can get your hands on it there. This thing is not completely free. We do have sponsors there that we tell you about. Chronic Disease Solutions is a CCM company, so if you're having issues with your CCM services, I know a lot of people haven't quite got that up to speed yet. That is a great way to make additional money as a rural health clinic. The rates have gone up dramatically. I think they're up to $63 to $67. I can't remember which one it is, but it's a lot for 20 minutes of time for rural health clinics starting in 2019. Went up from like $43 or $44. So if you need somebody who's got a real good reputation with our clients there, I know they've referred to us from our clients that you need to look into these guys, and they've got a real good reputation with chronic care management. So keep that in mind. You want to talk to them. We are going to get into cost reporting now. And if you know me, if you see me, I am 6'9". This is an actual picture of me in grammar school around Christmas time. So, and it does feel like Christmas. Cost report season comes around much faster. Seems like it's just over with, and it starts all over again. So and it's definitely Christmas around here as far as the amount of stuff we have to do. Deadlines for 2018, just so you know, if you were trying to claim Medicare bad debts for your 12/31/2018, it's too late now. You can't write those off. That'll be a 2019 bad debt write-off. If you're back in December, back in October, November, if you did write those off, then you can include that in the 12/31/2018 cost report. But if you've not done so, you can't pull together a list and write them off. As we have some people that they'll write the stuff on May the 21st and think that it's going to be eligible for a cost report in the prior year. It's not going to be. It's the date that the account was written off on Medicare bad debts. So that's not going to work. If you're a corporation and you accrue a bonus, that bonus to an owner, it has to be liquidated within 75 days. So you guys that are brand new to the RHC program and you're in your what's called base year, we need to talk about accruing you guys a bonus and liquidating that within 75 days if you're in, especially if you're in Tennessee where we had the moratorium and you weren't getting that money all that time. Now you're starting to get that money from being a rural health clinic from TennCare. I know Danny has filled out a ton of the quarterly settlement reports, and I've seen some of our clients will get some real money here pretty soon. And so we need to accrue you a bonus and then liquidate that before March the 16th, which you'll be happy for that because you're going to get a nice big check. But you have 75 days if you're an owner to liquidate any accrued bonus. And we really need to do that for a lot of these Tennessee RHCs that got caught in that moratorium. It's going to be very important that you do that because you want to capture all the expense you can in that base year cost report. Liquidate your accruals for non-owners. You can accrue a bonus. If you want to accrue a bonus to Mark and Danny for doing a great job on your cost report, you can liquidate that within 1 year. You may want to do that with people, with your employees. I know we had one clinic that they had a lot of employees that were there for 20, 25 years, and they accrued them a bonus that they liquidated within 1 year. So that works perfectly fine. That's perfectly legitimate expense according to Medicare. And if you've not signed up with the enterprise EIDM system, then go ahead and do that now. You need to sign up because that's the only way that we can get your PSNR, unless we just have a little bit of luck to get that. So your PSNR report is a provider statistical summary report. and it will tell us how many Medicare visits you had, how many Medicare charges you had, how much Medicare paid you during the year. That's going to be very important that you sign up for that, and then we will have some links to show you where you can do that if you haven't done already. If you haven't updated your passwords, you're going to have to do that every 60 days. So just have a tickler file on that for every 60 days. You need to update that password. Otherwise, you have to start all over again. In the cost report submission that you send to us, we want you to make sure you send us all of your cost report letters, even the ones requesting a cost report. Also, Palmetto and Novitas and a lot of different MACs have started giving you tentative settlements during the year for your flu, pneumococcal, and bad debt. And some of those are pretty big. I know I can remember seeing one we had $25,000 of money that was paid to you as an interim settlement. It's almost like an advance payment for influenza and pneumococcal shots that you gave during 2018. So if you received any of those type of payments, let us know, because we have to put that on the cost report. If we don't put that on the cost report, then you're going to get a big tentative settlement back from Medicare. And when they come out and finalize it, you're going to end up owing that money back. And you're going to be mad at us, and you're going to be mad at the world because you had to pay back $25,000 or $50,000 to Medicare. And so make sure you give us those letters, because there's no way for us to know unless you give those to us. Get your stuff in early. Let me tell you, I started working on some cost reports yesterday and today. The first ones where we're using this new form 22217. And we have to start from scratch. In the past, we'd had 25 years worth of cost reports in our HFS system, and I could click in there. All the stuff was already set up for us. All of your prior year information was there, and within 5 minutes, I could get going working on your cost report. Now, I have to go back and enter in a ton of information. Danny will be entering in a ton of information. It's going to take us an hour or longer just to get in the basic information into these cost reports, just to double check everything, make sure everything is right, and then we can start with the numbers and working on that. So the later you get your stuff to us, the worse it's going to be as far as us having time to do all of that. And we're definitely going to be pushing to do things a lot faster. Also, the earlier you get stuff to us, is we can identify these Medicaid base year cost reports, and we can accrue a bonus to you within 75 days. That will really work out well for you. If you are eligible for a no or a low utilization cost report, we can go ahead and get those things submitted ahead of time. And there's certain timelines that Medicare allows you to submit low and no utilization cost reports. Most of the MACs don't really, they sort of ignore them. But just in case they were to get serious about enforcing those, we want to get those in and done as soon as possible. They're very easy to do. We want to get them off of our books and out of your hair as soon as possible. And of course, getting the PSNR report, if you start right now, you're going to have a hard time getting it. So the sooner you should have started on that, the better off you are. Again, writing off Medicare bad debts. We had a session in December reminding you to do that as well. And again, our cost reports are much better this time of year because when we have a lot of time to work on them. By the time May 31st rolls around, we are in the emotional exhaustion stage. We're in the physical exhaustion stage too. So we are like everybody else. And I know there's a lot of cost report preparers on this session today. We're just like them. The sooner you get them into us, the better. Here's the caps for 2018 when you're doing your cost reports. $83.45 is the cap for 2018. If, like the one I was doing today, it was a September 30 year end, if you go back in 2017, your capped Medicare rate is $82.30. And if you're doing a projected cost report for 2019, getting your rate set, then you're going to want to use above $84.70 per visit for an independent RHC. If you're provider-based and you're less than 50 beds, there is no cap on Medicare. And in a lot of states, there's no cap on Medicaid either. So if your Medicaid rate is 100, the average, in Tennessee, they published the Grand Division average rates per visit. And I was pretty blown away. The average rate in the western half of the state was 141. In the eastern part is 131, and in Middle Tennessee, surprisingly enough, it was 137. So those are pretty good rates from Medicaid. So keep that in mind. Let's see here, and then this getting on to what's changed for 2019 cost reports. Cost reports stayed the same for 25 years. We used the form 22292 was what the technical term was. Now we're going to use 22217. And if your cost report prepares, if you're using HFS software, it right now my system reverts right into the 22292. You actually have to change it to a 217 when you start working on your cost report. So you make sure you toggle down and you're using the correct form, because otherwise you're going to waste a bunch of time entering in information there. I've got somebody with their hand up, so let's see where the hand up is and see if we can help. Kent has his hand up. All right, Dr. Winblad, let me see if I can unmute you. Okay, Dr. Winblad. Oh, nope, wrong one. Sorry, Andrew. Where did he go? Nope. Okay. And Kent doesn't have his name up anymore. Dr. Winblad knows where I am. He can call me on the phone if he needs to ask me a question. Let's go ahead and continue on. And you can always hit in the questions up here if you want to type in a question as we go along. Danny, if you'll watch that for me and alert me that there's questions on there, that's probably an easier way to do that. We will have a little time at the end for you guys to ask questions as well. So first major change in 25 years, there will definitely be a learning curve for the people preparing the cost reports and for you guys as well, because there is a lot of stuff that has changed this year. That's about the way I felt when I was working. I'm working on my first cost reports today, and it felt like I was hitting a brick wall. Every time I turned around, there was something different that I was not anticipating. And we will go into this one in a minute here. I'm not going to read all of this. If you saw my article in the National Association of Rural Health Clinics webinar newsletter that they sent out for winter, my article was in there, and so this was basically I basically just cut and paste that in there. But there's big changes that are coming along. Here are the regulations. It's about 95 pages of regulations. These apply to cost reports ending September 30, 2018. Believe me, I double checked this morning to see if the cost report I was working on, I had to use the stupid 22217, and sure enough, I do. Chapter 46 is going to be your Bible for this, and I really don't know it as well as I should. I know Danny's been reading it a lot the last couple of days. He keeps asking me very hard questions about it, but here's the instructions. It also has actual sample forms if you want to go in there and look at it. If you're using HFS software or Pete Marwick's software, KPMG, they have the vendor codes in there. I'm trying to remember. I think they're a 3, and HFS is a 3, and the other one, KPMG, is a 4. So remember, look through these closely. This will help you as you're starting to file these cost reports this year. Let's see here.
Hey, Mark, you have a question.
Okay, what's the question?
We had 3 RHCs all filed under the cost report. One of the RHCs received a much lower rate from CMS than the other 2 who received the exact same rates. Why is this?
I don't know. I don't. Are they filed a consolidated cost report?
The way her question reads,
yeah,
it makes it sound like they are, but I'm not 100% sure.
Yeah. Why? I really don't know the answer to why you're getting different rates. I mean, if they were a consolidated cost report, yeah.
Brandy Gordon, and she said you file our cost report.
Okay. I'm trying to remember which one that is. Brandy, call me after it's over with, and we'll find out why your rate is set lower on one of them.
Oh, no. We've got multiple people. It's Dr. Reddy.
Yeah.
Dr. Reddy's practice.
Okay. Well, they should all have the same rate, especially, I mean, that's a consolidated cost report. and it's above the cap. So they all three should have the same exact rate. Basically, sounds like something fell through the cracks with the Mac. So we'll just call Palmetto and tell them that, hey, we need to get this rate looked at, because I know that one is they're above the cap on all of those. So okay. Why are there any more questions there?
No, sir.
Okay. All right. Why change? The couple of the reasons are, number one is you can file electronic cost reports now completely with rural health clinics. Before, you could do it with hospitals and you could do it for other provider types, but rural health clinics, and I think there's one other provider type that you could not file an electronic cost report completely. You still had to have a wet signature with RHCs. Now we can file the whole thing electronically. Now, we're not going to do that this year because it's going to be hard enough just getting this thing done in the format that they want us to. And you have to go into that EDIM system and set us up as a cost report preparer. And there's a special thing that you have to go through. It's going to take probably a couple months before you guys can do that. So we are not going to do that this year, but next year we'll work on getting that done, and we'll probably do that with some of our cost reports when you're doing 150 of them and maybe 125 of them are due by May 31st. Doing it electronically this first year is probably not an option for us, but we'll start working our way into doing that. So here is the website where if you go in here, okay, something's wrong with our link there. I have noticed that some of these links have been going bad on me for this MCREF system. So I think they're making changes to where things are that maybe it's not going as smoothly as they want to do. But the main reason why the changes is this MCREF system. MCREF is a place that there's no longer, the Macs used to have this thing like Kahabi used to have this thing called Insight, where you could file cost reports electronically to your Macs. You can no longer do that. That's not an option. You only have two ways to file a cost report now. One is electronically, and two is by paper. And we're going to send them in by paper. We're actually you'll have a USB drive that will be your official cost report, and it'll have an electronic file in there, and you're going to sign on there. We're going to ask you to sign in blue or red ink. You're only going to sign in one place this year because there's no 339 questionnaire anymore. That's incorporated into S-2 of the cost report. So that'll be one less signature, but do sign it in blue or red ink and then submit that to them. As always, we're going to send you a cover letter of where to send it to, and it's going to have a little sticky note on it where to sign it, and you basically have to sign and send it. And then we're going to give you a nice little leather bound looking little booklet that will have your cost report in it for your records. So also there's going to be no FQHC information in there. FQHCs used to share the cost report with rural health clinics. They moved out in 2014. They use a form called a 22414. So we don't have to fool with skipping the FQHC information in there. And of course, the 339 questionnaire, like I said, is no longer being used, although we will fill out some of that information as well. One of the things that's going to be the hardest for me, as you can tell from my beautiful white hair, that I am old as the hills. I am an old dog, and cost centers are completely set up differently now. So that's going to be a change for me. So let's take a look at what's happening with these new cost centers. They've expanded the number of cost centers and added specific cost centers for pneumococcal and influenza. And I just learned that this morning was when I was working on that cost report was you have to have your flu and pneumococcal shot cost in your trial balance, or you're not going to get credit for it. So Danny, what that means is when we get those invoices from the client, we're going to have to make a reclassifying entry to pull those expenses out of medical supplies and move those into cost center 30 and 31 for influenza and pneumococcal vaccine. Otherwise, you're not going to get credit for those expenses. I know the first ones, the cost report I was working on this morning, I think I had a cost per injection of like $4 for pneumococcal and about $2 for influenza. I was like, what's happened? So started looking back to it like, oh, okay, that's what's happening. So remember, you guys are preparing cost reports, is we're gonna have to put that directly in your trial balance. You're gonna have to make a reclassifying entry this year. And for you guys that are pulling information together for cost reports, is in your trial balance, you need to have a separate account number for pneumococcal vaccines and for influenza vaccines, and keep up with those expenses during the year. So when you give that to your cost report preparer, they can just enter that directly into that trial balance, and you'll be insured to getting your proper amount of reimbursement for your pneumococcal and influenza. Because we all know pneumococcal vaccines are going to cost. I mean, you get paid about $300 for a pneumococcal vaccine, depending on whether it's Prevnar 13 or 23, or if you use the older version of it. Telehealth is down in cost center 79. Let me tell you, that's not the place you want to be. That's in the non-reimbursable section. So if you're doing telehealth, that's going to be non-reimbursable. And chronic care management is the same. It's going to be in the non-reimbursable section as well. So now
Hey, Mark, you have questions.
Okay, what's the question?
One of them is there a difference in reimbursement for the high dose flu doses that were given, because those vaccines cost a lot more than the regular ones?
They all get lumped together. So they don't. So if you give, and I guess it depends on the ratio of which ones you give, but all of your high dose and your low dose and your 13s and your 23s, they all go in the same pot. So it's based on average. They don't have a special, like there's only two different columns on the cost report. One column is for influenza, the other column is for pneumococcal. And now that cost will go into that expense for that particular area, but you're not gonna, there's no way that they separate it out. So it just depends on the average, what the average is. Hopefully, and I think you probably do get screwed on a little bit because you probably give it to more Medicare patients, and that average probably hurts you a little bit. But that's the way Medicare does it. Okay. Any other questions before we move on?
Yep, you got two more. One of them is our fiscal year end is March 31st. Can I write off the Medicare bad debt until year end like we always have?
Yes, you can. So I apologize for that. Yes. I was thinking 12/31 year ends, but absolutely, if you're a 3/31 year end, you can write those off now. So that's perfectly fine. Okay, next question.
Your last one is there was a major problem with Cahaba as an intermediary where they paid HMO claims as Medicare primary. There is an issue with the coinsurance and bad debt from these claims. Is there a provision for filing these for these bad debts?
Not that I know of. I mean, I have not heard anything about the Cahaba sort of fiasco on that. I think it's just died, and I don't think they're going back after that money in any form or fashion. And I've been sort of scared to ask anything about it. So as of right now, there's been no provision for that. Now, of course, a Medicare bad debt, if there's money that you don't collect that you billed to Medicare Part A on a UB04, things like your copay and things like your deductible, if you didn't receive that money, that's the only money that's a Medicare bad debt you can claim. But if you don't collect that copay from the patient or the deductible from the patient, and you make a reasonable collection effort, that means you have to try for at least 120 days. You have to send them 3 or 4 statements asking them for that money. Then that is a Medicare bad debt. So I don't think what you just described would even qualify for a Medicare bad debt anyway, because I think that was more of a primary payer payment from the MAC. Okay, let's go on here. This is what the cost report looks like, lines 1 through 39. I basically just cut and paste the new ones. And one thing that's very important to look at here is this line 5. It says registered nurse. When you read the description of that, that's only registered nurses that were in the the visiting home health, the visiting nurse program. So none of our clients will have that. Nobody will have that. There's maybe 2 of these in the whole country that have the visiting nurses, and Medicare pays for them. Where we're going to put our nursing cost are, we might put them in LPN, or we could put them in 10 other. This first section here is basically for salaries, lines 1 through 10. The first cost report I worked on, I'm going to set up nursing as number 10, and that's where I'm going to put my salaries in right here, and then we're going to reclassify them to the proper place. 15 and 16, these are your physician contracts for your medical director. This is where you're going to be putting those, depending on whether if they see patients, then that's going to be physician services. If they don't see a whole lot of patients, then that's going to be physician supervision. And then here's your medical supplies, your malpractice premiums. They're asking a lot of questions about malpractice premiums this year as well. So we've added some information about that on our checklist as well. Pneumococcal and influenza. This is 30 and 31. This is going to be very important that you get us that information. Otherwise, you're not going to get paid for that. There was the cost centers where it describes what can be put into each one of these. Again, it says here LPNs who perform visiting nurse service as well. So 6 won't work and 5 is not going to work. So we're going to use 10 for our nursing cost, and then typically we put line 10 or we put nursing as your total salaries, because most times when, like the cost report I worked on this morning, it had total salaries were $999,000. That's the only number I got. Now I'm going to go back through their W-2s and see, okay, the physicians were paid $200,000, the nurse practitioners were paid $300,000, and the nurses were paid $400,000. And I'll make what's called a reclassifying entry to get everybody's cost in the right cost center. So line 10 is what we're going to be using for our cost center this year. Here's your facility overheads, lines 40 through 74. So your facility, and you can sort of break it down in 2 components here: facility cost and administrative cost. And if you're in Tennessee, be very careful about using these lines 60 through 68, because in Tennessee, there's a 30% cap on administrative cost. So I think same thing might apply in Kentucky as well. I think I read the KR the other day, and it talked about a 30% cap on these types of expenses. So keep that in mind. These type of expenses will be capped, so you don't want to use 60 through 68 if you still have a base year cost report to be filed with TennCare. If you're in Kentucky and you've already filed that one Kentucky cost report that you had to file, then you don't have to worry about that either. So facility overhead, again, these numbers are different. It's going to be hard for me to memorize these numbers because I had the last ones memorized. Non-allowable expenses, so lines 75 through 100. And again, they have sort of 2 different sections here. Cost other than RHC services. What that means is these are things covered by Medicare, but not allowable on your cost report as an allowable expense. Things like telehealth, things like chronic care management. And what we're going to do is, Danny, I'm setting up line 81 as laboratory. 81.01 will be technical components or things that you build a Medicare Part B fee for service, and 81.02 is going to be hospital services. And then non-reimbursable costs, those are things that aren't covered by Medicare, things like if you did cosmetic surgery, those cosmetic services, things that aren't medically necessary, you would put those expenses in the non-reimbursable section. So that's where we're going to put laboratory technical components. It's going to be in line 81. Again, if you do telehealth and chronic care management, those expenses are non-allowable on this cost report, and it will actually reduce your cost per visit. But hopefully, if you're like most RHCs, your cost per visit is about $100, $110 a visit. So it's not really going to hurt you because you're so far above the cap anyway. Okay. Here's some of the additional information that's required. Malpractice premiums, paid losses, self-insurance. Again, a lot of questions about malpractice for some reason. I have no idea why. And then they want your visits broken down between medical visits, mental health visits, visits by interns and residents. They want them broken down in that format. They also want your visits broken down by payer mix. In the past, I've always said, I don't care anything about payer mix. I don't care if they're self-pay, no pay, commercial, whatever. Well, now I care, because we have to put this information on the cost report. So Title V, that's a CHIP program. That's usually the enhanced Medicaid for people that are over, 140% of poverty. They have a CHIP program for the children. So those patients are paid under Title V. Title 18, that's our old folks like me that are on Medicare, which I'm not quite yet, but well, I'm getting there close. And then Title 19, those are the poor folks like me. Like Medicaid, I should have applied for Medicaid. Medicaid is on there. So Title 19, and then of course 4 other commercial, self-pay, etc. Those 4 categories, we need your total visits broken down by that in order to put that on the cost report correctly. Here's our new form. When we send you out your cost report checklist of information to get, we've sort of broken it down this way. And if you would fill that in for us, that would be helpful. We have a new worksheet S-3 that we have to complete that. So keep that in mind. There's also date certified. Usually we pick that up from your letters. And if you're no longer a Royal Clinic, if you're decertified or you decide you want to terminate, which we have a lot of people that once after a long time, if they're an independent RHC and they get really super old like me, they decide that Royal Health Clinic's no longer for them because they have so much more Medicare, and actually sometimes Medicare is better fee for service than it is as a rural health clinic. It all depends on what type of providers you have, how busy they are, how many visits you guys have. So it's very complex, but like I said, a lot of times the older physicians tend to decertify because they don't have as much Medicaid anymore. And if you had a change of ownership, they're going to show that as well. Now this is something, and Danny, we got to add this to our checklist here when I was working on cost reports this morning, was we have to add the first name, the last name, the title, and the email address of the person who's going to sign the report. So that's information they've never asked for before, but it has to be electronic. It has to be input into your system before it's going to accept this as a fileable cost report. So we need to get the name of the person who's going to be filing this cost report and their email address in order to do this. So and then also, if your clinic is part of an entity that owns or leases multiple RHCs, then they're going to want this information as well. So I ran into it this morning on the one I was working on. There's 2 of them. They're owned by an county authority, and I have to get the information for the county authority to put this in here. And the HRSA award number, I'm not really sure what that one is. I'm going to have to look that one up to figure out what that is. There's a lot of strange things they ask them for in this one, which we will show you here, like this core-based statistical area, CBSA. They want your CBSA. And I looked, of course, you Googled it and found out what it meant, and Wikipedia there. And then after a while, getting a bunch of errors, I put in a number, I think 41. I was looking, Tunica is where I'm working on today. And so I found it right here in Tunica. And I said, oh, okay, it must be in the Memphis one. And I think they gave me a number of 31 or 41 or something like that. And it wouldn't accept that it said it was the wrong number. And then I looked up in the tools in the HFS software that we use. It has a lookup tool in there. So you guys can look up this CBSA and put that in. I think it's in worksheet 2, part 1, column 3. You have to put that number in there, or it's going to give you an error message in there for you guys that are preparing cost reports. So just.
Hey, Mark, I will say when I was preparing some yesterday, if you just put in the address and the city, state, and county, it'll automatically populate that code for you.
Why did it do that for me? Oh, maybe because I put it in wrong to begin with. That's probably what happened. Okay, well, good. All right, Dan. So it automatically populated. Okay, perfect. Well, for you guys to prepare cost reports, you don't even have to go in the tools section to look it up. If it does it for you automatically, that is awesome. Here is the PSNR reports on how to get those PSNR reports. And Danny, you can help me. Let's see with that. Let's see if this link works for them. Yeah, that's where you're going to go. I think this is the one that didn't work. EIDM. Yeah, see that one doesn't even work on the site. So I don't know what's going on, why the EIDM isn't working. But if you click here, registration and log in, you guys can, if you're a new user, you're going to go in here and you're going to register on the EIDM. And then, Danny, you can correct me if I'm wrong, then you have to register to get your PSNR report. Is that right?
That is correct.
Okay, that's what I.
The EIDM takes the longest because you have to verify like the CP 575 from the IRS, and then somebody else has to verify that you're a direct employee of the company.
Okay.
And then once you do that, you can request access to the PSNR/STAR portal within that.
Okay. And once you do that, what you're going to ask for is a report, a 711. That's going to be, or sorry, 710 is the report you're going to ask for, and a 71S. Those are the two reports that you're going to ask for, and those are the ones we're going to use on the cost report. 71S is if you've had preventive services, and the 710 is for your core services. Here is what I got on this one this morning. They sent us this report called a 711. And remember, now we have to use all these weird revenue codes for our claims. Used to, we just had 0521. We basically had an RHC claim, and that's all we'd ever have on there. Well, we no longer, we have, revenue code 0250 for our pharmacy items, 636 if you have an injection there, 0300, that's for your venipunctures, for your 36415s. And in this particular clinic, you can tell they charged a penny for each one of these services. You can either charge a penny for these ancillary services and then bundle the actual charge into the CG modifier, or you can actually charge everything, and these numbers will be higher if you actually use the actual charges for that. So either way is fine. Just remember, you don't enter this information on the cost report, especially these units of service. That would really, you would have some bad things happen if you entered those units of service, because you'd get overpaid from Medicare dramatically. So keep that in mind. Don't put 710 in there. Now, here's the instructions. We already showed you that, chapter 46 for this, so that's perfect. So you know that already. Here is the e-filing, MedLearn Matters. It's about a 4-pager here. Let's go into it, just take a real quick look at it. And so this is what you're going to be looking for. It basically just tells you that they've changed everything. It talks about no longer, the wet signature problem is no longer there with MCREF, and it gives you the actual, if you wanted to click into the actual MCREF website to go in there, then you can see here. You can see it's EIDM. It's very similar to the one that we just showed you. So let's see here, and let's go back to this. So that's your MedLearn Matters, and then your MCREF FAQs. Here's what your FAQs look like as far as just questions and answers from CMS for these. I won't go over all these. I tried to read them this morning and I got bored. I didn't get it quite finished. But by the time it's over, Danny and I will have this thing read and we'll figure everything out by then. Again, there's going to be a learning curve this year, especially for this old dog it's hard to get this. Here is our checklist for cost reports. I revised this thing last week, and I'm going to revise it again today when I get finished here, because there's some things we're going to have to do on here. But you can see this is our checklist for things. There's that tab 2 that I added for that. Let's see, the rest of the stuff was the same, but you're going to see stuff here for malpractice premiums, paid losses, self-insurance cost. We're going to ask you for that. I'm going to be asking you, there'll be another line for who's going to sign, the first name, last name, email address. A couple other things are going to be on there as well for that. So like I said, we're learning as we're going with the new stuff here. If you haven't clicked into all the stuff that we put on cost reporting, it's on our website at ruralhealthclinic.com. You can go into here. There's for cost reporting for 2019, a visit count checklist. There's our that checklist that I just showed you, how to sign up to get your PSNR. There was a presentation that we did at the end of last year as well. And then there's that article from the NARHC that I did on cost report changes as well. So make sure you want to double check that. I mean, a lot of times if you go in this resources section here, you're going to see a ton of stuff in here about RHCs, about what you need. Certification, if you guys are brand new, I know we got some of you guys that are becoming rural health clinics. We have webinar recordings about getting ready for the RHC inspections. There's a PowerPoint presentation by Kate on RHC. LC's got one. So there's a lot of good information on here that will help help you prepare for your either your reinspection, or if you've never been inspected as a rural health clinic. There's a lot of information on there as well. So let's go through here, and then I just showed you that website. Again, that's just a link that just shows you some of the stuff that we just showed you just now, so I won't have to go through that again. Before we go in to this MCREF information here, I probably do, because we are sort of running on time. We're on 45 minutes now. I did want to take you real quickly just to look at the cost report here. We use HFS, and so you can see this is HFS. Make sure that you get the form 222 22217. And let's see here. Let's find. Not as you see. This is this S-2 questionnaire that's built in. This is the 339 questionnaire that's built in. You are going to have to put in the person, whoever prepares your cost report, you're going to have to put their information built in into the cost report itself. So that's your S-2. S-3 visits. This is where we're putting in those visits on S-3, were Title 5, Title 18, Title 19, and other. And these aren't real numbers, by the way. They're sort of drafty numbers there. Here's your trial balance of expenses that we're putting in here, so you can see it looks like basically the same as it was before. It's still called Worksheet A. It's just got a lot more sections to it than it had before. And again, this 30 and 31, those two those link to Worksheet B, but Worksheet B-1. Here is your, let's see here, Worksheet C, Part 1 and 2. There's where you put in your cost per visit calculations. Here's where I'm putting in the PSNR data. And what's important about this is it's page 2, page C1, Part 2. This is where you put your paid monies. That's different in years past, where it was always on one sheet. Now it's on 2. So remember to put it back here. And then this line 2, this is for those interim payments. Remember I talked to you about if you got extra money for flu and pneumococcal during the year, that's where you're going to put that information. So make sure you send us copies of those letters so we can have that and put that information in there. Otherwise, you'll get overpaid, and you're going to have to pay money back to Medicare. Here is where this is the Worksheet B, looks pretty much the same. We're going to have your FTEs for the number of physicians, nurse practitioners, and PAs that you have, and we have to have those visits broken down as well. That information is not going to change. Here is your B-1, your flu and pneumococcal. Notice here, you were asking me, do we get more for high dose? No, you don't. Everything is lumped together in here. And so, and notice how our pneumococcal vaccine cost is going to come in, direct cost is going to come in from lines 30 and 31 from the Medicare cost report. So it's not going to, where is it? I don't see it on here right now, but it does come directly in. There's no way to enter in the data. There we go. I was right on it. Vaccines and related medical supplies from Worksheet A. That number right there, there's no way we can enter that. So you have to make a reclass to get that one correct. And so typically this pneumococcal is going to be close to $300 per shot. And then this one over here for influenza, it's going to be around $40 to $45 if you're looking at the benchmarking from a WIFLE. They put out a benchmarking report. If you're a member of the NARHC, then you can get that report. And it's a really good idea to pull that report and see how you guys are doing. A-8 adjustments, they've changed the titles of the worksheets now. It used to be A-2, now it's A-8. It's sort of in line with what the hospital cost report is, because I never could get used to calling them A-2s and finally get used to doing it. Now they're going to be called Worksheet A's. That piece of it is not changed any. You will, related party transactions, you are going to have to pull that cost out just like you have in the past. And there's the A-2-1 form remains pretty much the same as it was before. And then A-6 reclassifications, that's exactly the same thing as A-1 reclassification. So you will be using more of them this year because you're going to reclassify that flu and pneumococcal cost as well. So let's see here. All right, 302. We've been going 47 minutes or so on cost reporting, which I'm surprised anybody is still conscious at this point. Let's go. Whoopsie. Let's go back in here real quick. Let's see here, and let's see. Where did we get stopped? Right. I tell you, do we have any questions? You want to open up the lines for questions here? I think we're probably, there was some stuff on MCREP that I was going to talk about, but it's just for people that are preparing cost reports. So I think we'll pass on that for right now. Let me see here. Rate setting. I tell you one thing, be very careful. Medicare wants to always set your rate at $50 a visit when you first get started as a rural health clinic. Let us know, and we can get that fixed for you, because it should be at least the Medicare cap. So keep that in mind. Also, a lot of you guys with Palmetto and Novitas, you're getting these letters saying, what's your flu, what's your pneumococcal, what's your bad debt. We can add more money. They'll actually pay you above the cap. That's perfectly fine if you want to get that money, but remember, you may have to pay some of it back if your Medicare visit numbers change substantially, or the number of influenza and pneumococcal or bad debt changes dramatically. But if you're willing to take the risk of having to pay some of that money back, that's perfectly fine. If you don't like having to pay money back to Medicare, then I always tell our clients, just have them pay your capped rate and then settle up with it on the cost report at the end of the year. That's up to you guys on how you handle that, but that's important there. Also, always send us, anytime they have adjustments or any type of tentative settlements, send us a copy of that, fax that to us if you need to. If you can't copy, scan it or whatever, make sure whoever's preparing a cost report has that information, because it's very important that we have that information so we can file an accurate cost report. Okay, if you have questions, here you
Mark, there's a couple.
Okay, you can type those in, or you can also raise your hand if you want to talk. You're more welcome to do that. All right, Danny, go ahead and give me the questions, and I'll look for people with their hands raised.
Okay. When visits are broken down by provider type, do we also need to break them down further into the insurance type?
No, we don't care about the insurance type. We only need those four categories that they talked about. We want Chapter 5, Title 5 CHIP visits. We want Medicare visits. We want Medicaid visits, and we want other. But that's more numbers for us to break down. That's more numbers for us to add, and that's more chances for us to make mistakes, is the way I look at it.
And then there's one more that says, have you already sent out the cost report package for 2018 reporting?
We don't send out those big, huge notebooks anymore. They would have been completely changed this year. I would still be working on them if we were. Basically, because of the cost of putting together that 200-page booklet, making copies, I mean, nobody does that anymore. And it costs a fortune to print them. It costs a fortune to FedEx them. And nobody ever looks at them anyway. So we don't do those notebooks anymore, and we probably won't ever do them again. But we'll communicate this way to people on that, and I'll probably write up some more material on cost reports and this 22217. We'll provide a little bit more information on those, but we'll send it to you electronically. We're not gonna pay FedEx $50 to deliver it to some of y'all places. Some of the places we have cost reports in are pretty far away. Okay, any other questions?
There's another one that says, what is the CHIP office visits?
Again, my understanding of CHIP is that it's people that it's basically gonna be children. And if you're in states like, I think like Arkansas probably has a lot of CHIP. I know Mississippi does, because the one I just worked on had those. But what happens is, and I think it's a part of the ACA, the Affordable Care Act, was that if people were over, like Medicaid covers people that are 100% of poverty or 140% of poverty, and then there's a certain number of people up to 200% of poverty that they can get medical care for their children. It's called the CHIPS program, and those are those types of patients. Is a CHIP patient. So that comes under Title 5 of the Social Security Act. And that's all I possibly know about it. I don't know as much as I'll probably be learning more about it as we go along. Okay, any other questions here? Any hands up? All right, people. If I hope I haven't thoroughly confused you on some of this stuff here. Like I said, we are definitely in the learning curve on doing cost reports. Get your stuff to us as soon as possible. I am going to put up a new checklist with some new information request on it as well, and we're going to get that out. We will send out a new a newsletter, and it'll have all the links to that. If you guys are in Alabama, we are going to be doing a sort of a one-day session down there with the Alabama Office of Rural Health. That's going to be at the end of March, so keep that in mind. It's going to be free too, so you get to spend 4 hours with me for free in the middle of Alabama if you want to. So please keep that in mind. I think it's, as of right now, it's tentative like March the 25th or 26th, something like that. So thank y'all.
Mark, you have a couple more that just popped in.
Okay. Are you almost letting me get away? All right.
The PSNR report that's on the portal, is it difficult for everybody to find the specific report?
Probably yes. Danny, you can answer that better than I can.
Yeah. So Rob, I can actually send you instructions like that step by step, and we'll walk you through what button, like what links to push to get to it. And if you still have issues, you're more than welcome to give me a call, and I can walk you through it that way. But there are instructions on Palmetto's website that walk you through specifically how to get to what you need and then which reports to pull. And then the other question mark is, how can we get a copy of the slides?
They're right in your little, it says handouts over here. Your slides are right there. You can all you gotta do is just click the little link and you're there. And we will post them in the Rural Health Clinic Information Exchange, and they will be on that website. The one about cost reporting, where did it go? Rural Health Clinic Cost Reporting. That website it'll have them there. Let's see, where is it? If you just Google Rural Health Clinic and then go into resources, and here it is right here, resources, and then go into cost reporting. I will actually put all that stuff up on here as well, so you'll get it. You can get it there. This is where that checklist will be, so we're going to update that checklist as well, and then we'll put the data right here as well. Any other questions? Okay. All right, guys. Well, thank y'all for attending. I know a lot of smart people were on there too. If any of you cost report people, if y'all know something and I don't know, please let me know. We'll be glad to share any information we have with you guys, and because I know we're all sort of all in this together as we go through this time of year trying to get all these cost reports done. Thank y'all for attending. This session is being recorded, so we will put the links out if there's people that need this as well. So thank y'all very much. We're going to end the webinar now.